They have very few symptoms or they feel like they're very well, but sometimes they also feel very sick. Okay. So what does that mean by airway inflammation? So if you look on the rightmost, no, so this is the diagram, no, the airways of a normal person. Right? So it's and then at the end of that airway, there's a little the alveolar sac. So that's where the air exchange happens. Anyways, so in the middle, so we actually the way the underlying that in the patients with asthma, no, even if they feel well, there's already a change. Iba na yung itsura ng airway ng asthmatic, even if they don't feel anything. Okay, so if you notice, no, the walls are thicker, there's more mucus being produced. The smooth muscles are always ready to contract or constrict. Much more so in a patient who has symptoms or is flaring up. Okay? So more mucus is produced, the muscles around the airways are more constricted, and so what the patient feels is, so overall, the airways are very tight, no? And the patient feels all these different symptoms. So what are these symptoms? Okay. So like I was saying, so sometimes it's a tip of the iceberg. So sometimes patients don't really feel anything or have very minimal symptoms, but underlying that there's a lot of simmering inflammation that may flare up at any time. Okay, so what are these symptoms that we usually see in patients with asthma? So number one is wheeze. Here in the Philippines, that's often described as huni or hanak. So it's an audible or a sound that patients make knowing the airways are very tight. Okay. Shortness of breath or hirap sa paghinga. Chest tightness. Some people have cough as well. No? So sometimes it's very difficult to tell them apart from other diseases with chronic cough. And then that variable expiratory airflow limitation just means the tightening of the airways. Sometimes it may be a little looser, sometimes it may be tighter. So usually how we monitor it in our clinics is through this machine, this device called the flow meter. But hopefully we can get more asthmatic patients to do formal testing with formal pulmonary function testing like spirometry here on the left corner. So there are different types of asthma, so there's not just one presentation of asthma. So different people, different asthma sufferers, even if they have somewhat similar genetics, they may have different manifestations. So there's these are just some of the more common ones. So there's the typical, what we see, yung allergic asthma. That's why allergists, ano ba ginagawa ng allergists sa asthma? No? So that's why we're heavily involved also in the management of asthma, because for a lot of our patients, the trigger for their asthma is an actual allergen. So on the background also of family history or personal history of other allergies, we see this kind of asthma. There's also non-allergic asthma. So the triggers are usually the triggers are usually irritants like pollution, maybe the actual temperature of the room, then there are also some people, and these are just different ways that the patient may present to us in the clinics. So what we usually see, or what our usual idea for asthma is, it starts in childhood. But and then it develops with other allergies during childhood, and we'll touch a little on that later. But there are actually other people who develop asthma in adulthood. So I get that all the time from patients who ask me, I thought this was an asthma because I'm an adult already. So there's actually adult onset asthma, or what they call late onset. And then there's also long-standing asthma where the persistence of the tightening of the airways. Usually the asthma is defined by Sometimes it will be relaxed, sometimes not so much. But sometimes in patients with asthma, long-standing asthma, they can have permanent or persistent airflow limitation. And there's also such a thing as asthma with obesity. So these are very helpful, these classifications in helping us manage patients or treatment. Kasi iba yung treatment po ng allergic asthma or allergic asthma alone versus a patient na may non-allergic asthma or asthma with obesity. So again, there are different types of asthma. One of the more common types is allergic. So we may view asthma also as a form of respiratory allergy, along with allergic rhinitis. No? Kung bahing ng bahing ko, usually sneezing in the morning, or colds, or post-nasal drip, no? That's allergic rhinitis. And it's very commonly associated with asthma. Okay? So it's what they call part of the allergic march. So one by one, these allergies pop up during the patient's life. Right? So this is what they call the atopic march or the allergic march. So in childhood, you have more of, if you see the blue line, no, that's eczema or atopic dermatitis. So skin manifestation po ng allergy. And then that usually occurs more, appears more first in childhood or even in infancy. And then you have more and more cases of food allergies also that usually appear in childhood. Then for asthma, you see the green line. The green line asthma may appear later, no? Usually during childhood. And then also with allergic rhinitis, the orange line, you can also see that develop later on in life. So essentially, these are usually they pop up. No, they don't have to follow that sequence of eczema and allergies, but just know that they can pop up at different times in a person's life. Okay, so what can trigger asthma usually? So asthma is triggered by allergens or irritants in the environment. So specifically for allergens, there's indoor and outdoor allergens. So and then for irritants, it would be smoke from cigarettes, from our vehicular smoke also, and from factories as well in our environment. And then other triggers can also be exertion or exercise, respiratory infections like me, no? I suddenly had an upper respiratory tract infection. That's why medyo malaki yung boses ko. So you can also have that as a trigger, and that's actually very common now. That's why we're seeing a lot of patients, are asthmatic patients with worsening asthma at this time of the year as well. Also, excessive laughing. No? Sometimes with the barkada, laughing a lot. And some asthmatics who aren't that well controlled can also have excessive laughter as a trigger. So these are examples or the very common allergens that patients can encounter. So indoor and within our own homes, house dust mite, cockroach, animal hair, and mold. So the cockroach, they don't actually bite, they're actually part of the dust, along with the dust mites. Animal hair, so cat and dog, but also sometimes if we have other pests like hamsters or something like that, or unintentional cohabitants like mice. So they can also leave their dander or their hair with their dust. Outdoor, things that can affect us will be tree pollen, grass pollen, and weeds. Pollen from weeds. Because these are the ones that fly in the air. No? It's a misconception that it's always flowers. No, flowers, pwede naman, but it's usually you have to be super up close for it to trigger. No? Unfortunately, for tree pollen and grass, it's carried by the air, so it can go anywhere and the patient can inhale or be exposed to these outdoor allergens. Common indoor allergens. So these are the two most common in the entire world, whether you're here in the Philippines or abroad. even whether compared to urban and rural settings, it's all the same. Most common would be our house dust mite here on the right, and on the left, that's of course common household cockroach. Indoor allergens are cute dog and cat. No, unfortunately, sometimes we will have to address also when we have these as our allergens. So in the middle, no, you have an example of mold. So outdoor allergens will include your tree pollen. Here in the Philippines, for trees, so we have very commonly acacia. So not so much this season anymore, but during the summer season, when you see that nice pink flower, not the acacia tree, it's actually the pollen buds. No? So for those with allergies to acacia, it's the time of the year to beware. And then you also have grass. So this is actually an example here on the bottom, that's kalahi. In the middle and on top is acacia. So other triggers, other than allergens, you can also have asthma triggers that are non-allergic, so environmental factors such as cigarette smoke, industrial waste, and vehicular exhaust. And then you can also have exercise. So even if you're trying to be healthy, sometimes it can also trigger your asthma. So exercise-induced bronchoconstriction. And again, like I mentioned, viral or bacterial respiratory infections. So first of all, like if you're an asthmatic, how will you know what your triggers are? So we advise our asthma sufferers to start thinking about or start trying to maybe take stock of what we usually observe that triggers our asthma. So is there usually a place where you get more of these asthma attacks? Is it at home? Is it in school or at work? Is there a time of the day when you feel your symptoms are worse? Is it morning, while you're in work or in school, at night, or early in the morning? Is there a season of the year or time of the year when your symptoms are worse? And is there a specific activity that triggers it? So like, for example, during exercise. So how will you, so further, how to elucidate your triggers? So you discuss also with your doctor. Sometimes it's very helpful to just really discuss not just the symptoms if you're for patients who are suffering from asthma, not just about the symptoms and how to take the medication. You also ask about doctor, what do you think are the common triggers? And then ask how also to avoid them or how to lessen exposure to them. Okay? Yeah. So if you're suspecting an allergic trigger, you may see your friendly neighborhood allergist. There are a bunch of us here in Manila. Okay? But in the Philippines, there's also well represented. Okay? So for us allergists, to try to figure out if there's an allergic trigger, we do a skin test. We can undergo skin prick test. Which is our diagnostic test of choice to figure out what the allergic triggers are. If for some reason we cannot perform the skin test, then there's actually a blood test that can help us also figure out what the allergens are. So, okay, so you know your trigger, so how do you avoid? So if ever you're asthmatic and you know you're or you can even observe from dust exposure that you're already getting triggered, then we suggest, these are some of the suggestions to help lessen your exposure. So regular daily dusting with a damp cloth, in other words, basahan, right? So we call it the wet rag method. So frequent change of bed sheets and pillowcases because dust might tend to collect a lot of in the bed and the bedroom. So please, and then also try to eliminate these dust magnets, stuffed toys, carpets, thick curtains, clutter, and certain upholstery fabrics that are friendly for the dust mites to enter the bed or the foam, the material of the mattress. Okay, You may also use a vacuum cleaner, but there's a specific filter that we suggest for patients with dust mite allergy. And then definitely, if you have dust or indoor allergens, we suggest to open the windows, even for just a few hours of the day to air. Now, for other triggers, if you have pollen allergies, you reduce pollen exposure by lessen going out during that pollen season, or close the windows specifically for that season. You may also go out wearing a mask. Now, look at the sad kitty. If for our patients with animal hair allergies, and then it's proven to be the cat, we suggest to remove the pet from the home, which is rather sad for some of our patients who have beloved pets who they turn out to be allergic. Definitely, sometimes we say definitely don't sleep in the same bed as the pets. So that's the sad cat who may need to be given away in case the owner is really allergic. Okay? So for cockroach allergies, we suggest also regular fumigation for cockroach elimination. So take out the dead cockroaches in your eggs so they don't become part of the nest. And please, 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 for any asthmatic, don't smoke. If you're the asthmatic, don't smoke. That goes without saying. But also, no smoking. If you are a smoker within the same home as an asthmatic, no, in and around the house, it has been proven that you can trigger a person's asthma even if you smoke outside the house, okay, in the window. Okay, so you're going to have to stop smoking for a period. But if you have an asthmatic in your home, we suggest not even around the house. Now, in patients with difficult to treat asthma or uncontrolled, we suggest for our fellow physicians to refer the patients, and for us also, we introduce the idea of immunotherapy or allergy vaccine. So they come now in two forms: the injected form, so right under the skin, or pwede na rin under the tongue, the sublingual, where the point of allergen immunotherapy is to make you more tolerant or to be less sensitive to that allergen, so you're not always getting flare-ups when you're exposed to that allergen. So knowing your triggers, so then knowing what we know now, that we know what asthma is, and there are certain things that trigger. So when they're triggered naman, and the patient is having symptoms, how do you treat asthma? So, unfortunately, like other allergies or other diseases, asthma is a chronic disease. It may be quiet for some time, and it may flare up sometime, but it is a chronic disease. There's no absolute cure for asthma. Okay? So we like to discuss with our patients long-term goals. So number one is, syempre, of course, how to make the patient feel better. So the treatment is centered on that, how to make the patient feel better when they have symptoms, and of course, risk reduction of further flare-ups. So this is worldwide. There is an international body that we collate all this information about asthma, and it's actually a group within representatives from our society, and even from PCP, are in contact with our colleagues from this group, the Global Initiative for Asthma, or what they call GIA. So this is an international collaboration where we get to where they put forth recommendations on how to treat asthma. So in general, so what does it mean with symptom control? So we generally ask this from our patients. So how controlled are your symptoms in the past 4 weeks? Do you have asthma symptoms in the day more than twice a week? So it's usually yes or no. And then any nighttime waking due to asthma, do you need your reliever or do you need medications to help you through an attack? And any activity limitation because of asthma. So they answer, and then if you have 1 to 2 of these, you are partly controlled or partially controlled, and not well controlled or uncontrolled if you have 3 or more of those symptoms. Okay? Now, so the second goal for asthma treatment would be to lessen the risk factors for poor asthma outcomes. So we assess all of that, no? So we want to lessen exacerbations or attacks of asthma, and then the fixed airflow limitation, and then of course, because patients who have more attacks need more medications, hopefully also to monitor the medication side effects. So hopefully we need less of these medications for the patients to be able to have less attacks. Okay, so these are risk factors, and now if these are the risk factors are high, those at high risk for poor asthma outlook or a poor outlook in the future for asthmatics. If you've ever been intubated or hooked to a ventilator for asthma, very poorly controlled asthma symptoms, having more than 1 exacerbation in the last 12 months, in the last year, low measurement of that of lung function. You have medication but you're using it in the wrong way. O baka pala dito sinspray sa tabi ng tutulo or masyadong malayo. No? There's also smoking for that asthmatic person, and other exacerbating factors like obesity, pregnancy, and high level of these eosinophils are type of white blood cells that are seen also in asthmatic in allergic patients. Okay, so other things that can other parang points in the history that will for patients na nag-exacerbate but and then have a poor outlook for the future. No steroid treatment, no inhaled steroid treatment. If there's smoking for the patient, if there's occupational exposure to the irritant or the allergen, if there's a lot of production of mucus, and again, the blood is increased. Okay? So actually, this is, again, this is a very, so just to flash, no, this is how we treat asthma, basically, no, the recommendations of how, what medications to give depending on the level of control. But generally speaking, there's 2 things in how to treat asthma. Asthma treatment falls either, the medication for asthma usually either fall in the controller medication, so they address that underlying inflammation, that earlier slide I showed you where there's like simmering inflammation. So you use these controller medications long term to address underlying inflammation to reduce the risk of the flare-up in the future. And then reliever for the patient for the symptoms that you feel now or for the acute attacks. Okay, so the reliever medications such as your short-acting beta-2 agonists or SABA, by itself, no, like salbutamol, the more commonly used medication here, or in combination with an inhaled corticosteroid, like formoterol plus or inhaled corticosteroid, are given for relief, no, for the symptoms or flare-ups. So the controller medications are usually inhaled steroid. Inhaled, so alone or in combination with a long-acting beta-2 agonist or LABA. So they're there to reduce that underlying inflammation and then to try to control symptoms and to reduce the risk for more flare-ups in the future. Okay. So before, if you had well-controlled asthma, the previous recommendation was, okay, here's your backup or your reliever medication. Use it only when you have flare-ups. Nowadays, no, because of that idea that there's always that simmering tip of the iceberg idea that there's always inflammation under seemingly well-controlled asthmatic, there's now a move to try to recommend to give, even if it's on an as-needed basis also, to start with an inhaled steroid as well. Not just your inhaled reliever, but an inhaled steroid with your reliever. So, for better asthma control. Other therapies will include and these may be used in conjunction with your other medications, the controllers and the relievers I mentioned before. These are for patients with persistent symptoms despite higher doses of your inhaled therapies. So you can have your leukotriene receptor antagonist or montelukast as an example. You have other inhalers such as tiotropium, your anticholinergics. Biologic treatments are usually injected treatments, and those are also viewed as a step up or like a controller medication for those with an allergic type of asthma, like your omalizumab. And then you can also have, but again, this is just additional therapy. We don't really recommend it as regular therapy, so oral steroids. So again, for allergic asthma, we consider allergen immunotherapy. So to wrap up, so for this season, for those of us who have asthma, for our patients who also have asthma, this is also the season during weather change or as the weather gets a little bit cooler and the pollen makeup changes as well. We have a lot of asthmatics this time of the year there now. So again, hopefully we'll keep all of these in mind, and hopefully for any asthmatics out there, we'll get you into your doctor's clinics. If you have any questions about knowing your triggers or anything about treatment or how to use your inhalers or your medications, hopefully we see that more patients come see their doctors about their asthma. Thank you.
Thank you, Doctora. Are there any questions from the audience or from the press? I'd like to start with my question first. Doctora, you showed that there's a way for us to determine what allergen we have, right? Yung pong skin testing. So baka gusto na nila malaman kung magkano ba yung skin testing if they go to the clinic.
It will actually depend on the allergies. We have different sources for our skin test panels. So it depends on the allergist who does the skin test.
Thank you. Because I think it's really very important for you to know para malaman po natin kung ano yung nagkakos ng allergy. So, maganda siguro talaga magpa-skin test tayo lalo na kung panay-panay ng takit. Sir, may tanong po. State your name po and your station.
Thank you very much. I'm Camilo Meliantes, KTV Philippines. I have a daughter. My eldest daughter has an asthma now. From time to time, he has some attacks. I really don't know because I have 4 daughters in the family. What caused her to be different from my other daughters? Is it because he was able to have a breastfeeding or not?
Lots of factors, sir. May I ask, are either you or your wife asthmatic or your allergies also?
No, my wife doesn't have it.
Or anyone in the family?
She's the only one.
Yeah, we see that a lot now. No? So usually we look for family, like I asked, we usually look for family history. But now, that's the problem with allergies. So we're seeing a lot of these new cases coming out with no family history. So, is it environment? Is it global warming? No? These are all factors that are playing into now that we're seeing a lot of new cases in families with no history. So, the answer to the question is rather vague, I'm sorry, but it's a host of different factors. So, kung wala pong genetics, like none in the family, it may be because of the environment, exposures, and everything.
Yeah, because there was a time that she did not bring the inhaler, no? In that particular case, it's quite fatal, isn't it?
Yeah, there are actually people here in the Philippines who still it's still an important cause of death for a lot of people around the world. So that's why we always suggest, no, even if you feel well, don't always have your inhaler, at least your backup inhaler with you. Schools should have, schools definitely should have their own, like at least a nebulizer. If you're also an asthmatic, be aware of your, I guess, your surroundings, wherever you can possibly either get an inhaler or nebulize. So it's very important to always bring your backup.
Suppose she's not able to bring it. Ano bang particular remedy, no? Sa ganon. Sa ganang sitwasyon. Anong pwedeng gawin sa kanya?
Marami po yung mga nagsasabi, like, I know what you're getting at, sir, yung mga sugar, yung mga gano'n. Hindi po, no? You have to get yourself to an emergency room, no? Or a clinic nearby where they have a nebulizer. So, to reverse the tightening of the airways, there's really nothing that sugar can do or fanning yourself can do. Sometimes, even for exercise-induced asthma, not even resting can make will only make a small difference if you maybe need to use an inhaler or an S or the nebulizer.
Maraming salamat, Dr.
Thank you very much.
Good morning po, na GBD Guzman of DWBL. Yung po bang, yung po bang pagkain ay po pwedeng maka-allergy din. Pero sabi ng iba, yung mga matatanda po, kainin mo lang kahit na-allergy ka, mawawala din yan. Magkakaroon din doon. May immune ka rin. How true is that?
I hear that all the time as allergies. So yes, food can be a trigger for allergies, no? Even asthma. So, even asthma. Yung pong idea na paunti-unti tas may immune that's if a child or if a person is really allergic because of that something, delikado, no? We may be setting that person up for, kasi parang yung konting exposure, no? Parang mas, yung susunod na exposure o yung susunod na kain, baka mas malala ng yung symptoms. So, yung susunod pa, baka mas, parang more and more naging violent or more and more worse and worse po yung reaction in mga ganyan. So, hindi po totoo na yung paunti-unti kakainin ba yung immune. Meron po na allergies na naa-outgrow, no? Some allergies in childhood, sometimes ito na rin yung allergies sa milk or yung allergies sa egg. Pero we suggest to kunyari mga bata po naman, sinusuggest namin sa mga magulang, stop niyo po muna. Give a period of around 6 months to a year na hindi niyo po papakainin or hindi papainom ng milk, tapos we retry, pero sa harapan po ng doktor. O sa clinic ng doktor kasi delikado po mag-react sa bahay.
Doc, would you mind to recommend some medication na over-the-counter na bibili? Kasi po, kagaya rin ng problema ni Kuya Milo, just like me, my son is also suffering from allergy, na hindi po siya pwedeng lumabas kasi dalawan sa naka-langhap siya na sa labas. Nag-trigger yung kanyang, asthma, yes.
May inhaler na po siya. Nagka-backup inhaler or meron po siyang maintenance na inhaler.
Wala po.
Opo, it would be very important. And most common na ginagamit naman po dito sa Pilipinas na backup inhaler would be yung salbutamol. I don't want to see the brand. There's new ano naman kasi, brands in market, but number one that's been being used as backup po yung salbutamol. And yun din po yung pinaka-madalas na ginagamit sa nebulizer din. But even then, nowadays, no, dahil nga po parang base po sa mga research, no, dahil nga laging merong underlying problem of that inflammation, yung tighter airway na na yun na po yung baseline talaga ng taong may asthma, we suggest baka dapat merong maintenance na po. Parang dapat meron na po siyang regular na inhaler na tinitake every day para maiwasan po mali. Baka hindi na po naglalaro yung yung sa labas. Kasi mausok talaga dito sa Maynila, so baka hindi na po siya nakakalabas dahil doon. And that's not a good thing, di ba? Ang gusto natin sa bata, maglaro sa labas, pumunta sa school, and daily, and be able to play with his friends. Kung dahil po sa asthma, yun ay nagiging issue, play or school, no? Dapat po, siguro meron na rin talaga siyang maintenance.
Doc, hope you won't mind po. Meron po kasing nagpapatanong. Bakit daw yung ibang doktor, magaling daw mag-advise, magaling magpainom ng gamot, and yet yung sarili nila, hindi nila magamot. Ano bang usually dahilan nito? Or may mga problema lang? We are speaking for reality.
Ako din lang po, no? May ibang personality.
Yes. Thank you very much, Doc.
Mabuti siguro yun kasi talagang expert yung doktor. No? Kahit hindi niya ginagawa, alam niya yung tama para sa Doktora, yung another question ko, kasi marami tayong napapanood sa sine, yung EpiPen, yung pag may mga nag-allergy, di ba may sinasaksak sila sa sarili nila? So, parang feeling ko kung may severe allergy, parang mabisa yata siyang gamot. Pero meron po ba nun dito sa Pilipinas, Doktor?
Unfortunately, that is what yung advocacy po ng grupo namin, the Philippine Society po namin of Allergy, Asthma, and Immunology. Gusto po namin available dito. No, what we have here is yung bote. Bote na bubuksan niyo pa, kukunin niyo pa yung dun sa syringe or dun sa hilinghilya, yung gamot, no? Tapos i-inject niyo. Mas maganda po sana if we could have the EpiPen here. Bubuksan niyo lang yun, tapos you can even use it through your nose, no, for severe allergy. So we're working on that. We're trying to bring it in, no? For any patients na may concern about the EpiPen, we try to make it available through our society, and we'll give our email address siguro. No? So if it's an issue of looking for the EpiPen, we'll help you look for it. But for now, foreign source.
So, any other questions? Last question, Doctor, regarding celebration of Asthma Week, are there any activities lined up for the public to go to for more information?
Actually, we celebrated it earlier kasi World Asthma Day is really May 1. So we've done mga dissemination in our own hospitals, but World Asthma Day is usually May 1, so it's usually that time of the year na mas nagkakaroon ng activities for us.
Thank you very much, Doctor.
Thank you very much.
So, if you want to take sound bites for interview Doctora personally, you can just approach her. We're just going to prepare for the next part of the forum. Thank you. Good morning, everyone. Welcome to the second part of our PCP Health Forum. I'd like to welcome our friends from the media and also our speakers. Medyo bigatin po yung ating lineup for today, no? We also have a former health secretary who's here. This will be moderated by Dr. Jean Solante, who is currently a board member of the Philippine College of Physicians and past president of the Philippine Society for Microbiology and Infectious Diseases. So this is, as you can see, no, a panel of experts. So now let's listen to what the experts have to say about the current epidemic, which is a very big problem in our country. So Dr. Solante.
Thank you, Lingo, and thank you also for the opportunity that you gave us here to expound on this very important topic, which is dengue. But before I'll proceed with the discussion, I'll have to introduce the dignitaries, the high-profile, power-packed experts. These are the real experts. And of course, we'd like to acknowledge the presence of our former DOH Secretary, Dr. Esperanza Cabral, who is our motivator. He always motivates us in our advocacy in dengue. Then first we'll have to start here, the President of the Philippine Association of Patient Organization, Ms. Gurley Lorenzo. She represents the patients. And then, of course, former Philippine College of Physician President and former Philippine College of Chest Physician President, Dr. Charles Yu. And then we also have representative from the Philippine Medical Association, no less than the Vice President of PMA, Dr. Benny Atienza. And of course, I think most of you here, you, Dr. Lulu Bravo, no? She's one of the experts in vaccines, authority in vaccines in the Philippines. She's representing the Philippine Foundation for Vaccination, and she's also our advisor in the technical working group of the PSMID Adult Immunization Group. And then to my left, I'll start with the current president of the Philippine Society for Microbiology and Infectious Diseases, Dr. Mario Panaligan. And then we have also a board member of the PSMID, Dr. Nimpa Putong. And the last but not the least, our current president of the Pediatric Infectious Disease Society of the Philippines, Dr. Ana Maong Lim. So, the current state of dengue infection in the Philippines really is really alarming. Okay? If you notice, the Department of Health has declared a dengue alert last July because of the unprecedented increase in the rate of dengue cases for the past year compared to last year's. And isa sa mga tinitingnan din natin, paano natin matutulungan ang Department of Health or everybody here, no? How do we inform the public? What is the importance of information? How to prevent dengue? And probably the other aspect here is really sustained awareness on the menace of this infection. So before us, I call each one of them. We'll have a short presentation from Dr. Charles Yu to present the actual experience of doctor who died of dengue, just to create that start the awareness of this particular topic. Charles?
Completely that presentation. It's more story. There is nothing more to illustrate the importance of dengue, which I know everyone is so concerned about, than to, I guess, share stories. The first story is the story of a good friend of mine. He was a past president of the Philippine College of Chest Physicians. He was an advocate in TB control in Philippine. He had been doing a lot of studies in the burden of COPD, which is also a big problem. And he was doing field studies. In the course of doing the field studies, he developed dengue. So, first sense. A year later, he continued to do the studies because he thought it was important. Despite the warning by his wife, who's also a doctor, and all the precautions, putting all the lotions, etc., he developed a second dengue and he died. That story is in one paper. He was one of the leaders in the pillars. He was actually the father of clinical epi. If the grandfather of epi is Dr. Ernie Domingo, Tato Dantes was the pioneer in clinical epi of which I belong, and others, Jefford and Comidanes. We all belong to that family. He's a great loss. He died at the age of 50. And you saw the last part of that article. So great a man with unfinished work, dying from a mosquito-borne disease. So that is the story that I want. So that his death will not, well, he has touched the lives of many of us, and we continue to be inspired by him. But one of the reasons is why he wants also us to share the stories, to say that dengue does not spare anyone. whether you're poor or rich, mighty or not, it will hit anyone. And so far, talo pa rin tayo ng mosquito at ng virus. My second story is very personal. In May, I came out in the summit that was organized by Yulu and the late Dr. Montalban. So, and I for the first time went public, although PCP President ako PCP, I've been to San Lucia. But I wanted to share the story of my son. I have a son who was vaccinated with dengue. Okay? I was scared because in my hospital, people were dying left and right of dengue. Our hospital in Las Marinas was overflowing with patients with dengue. And so, the controversy was already raging about the possible risk of the dengue vaccine. But I and my wife made an informed decision that we will vaccinate our son. And today, I sleep more soundly immediately because I know my son is protected more than others. The other thing is I share this with the hundreds of thousands of families whose children were vaccinated. Not many people know that before yung mass vaccination of 830,000, there were already large vaccinations involving the private sector, involving many of the internees, the infectious diseases that were there, including the family of our president, the daughter and the granddaughter. So we all share. We were concerned that we wanted to protect our children from dengue. And so this is some of the messages that we hope we will say. The vaccine is only one of the weapons in the war against dengue. Vector control, prevention, aggressive management, fluids. Those are all important, but we should not deprive our countrymen of an available weapon to prevent further dengue. It is not a weapon for the current outbreak. Kahit pakunahan mo pa yung mga batang yan, ang impact niyan in the next. And my last part is really more statistics because I'm more known as a TB advocate rather than dengue. So I did this amateur tabulation of statistics comparing dengue and TB last year and this year. Look at the total numbers identified between 2016 and half of 2019 up to June, reported by DOH. This will certainly exceed the 2018 numbers. The reason I raised that is because I think one of the senators actually said that there were also these numbers of inpatient PhilHealth claims of the number of cases of dengue. There's a little discrepancy and that needs to be corrected. But if you delete the numbers, the 174,000 in 2019 of PhilHealth, double that number almost approaches the total TB patients that we already see. Okay. Economic burden. Ito yung PhilHealth reimbursements. Last year, it was 2.4 billion. In the middle of this year, 1.7 billion. Remember, the PhilHealth does not fully compensate the inpatient cost. Ano lang siya, partial, maybe 50%. So more than that pa yung economic burden. Hindi pa kasama dyan yung outpatient dengue patients. Hindi pa kasama dyan yung loss of income from families guarding their children when they are confined. So that economic burden almost approaches the 8 billion. I raised this because there were concerns in the previous year. Bakit daw hindi TB? So me, the champion of TB, say, bakit hindi dengue? Dengue is like the house on fire. TB is like the termites that are going to destroy. But both are very important to be treated. I end with my own statistic in my hospital, which I just got a few minutes ago. In our university hospital, this is the current latest statistics for July. We have 130 pediatric dengue cases. We have 3 deaths. None of them had previous vaccines with Dengvaxia. We had 4 Dengvaxia cases. They all got well. We had 34 adults with dengue and no one had Dengvaxia. If you look at the latest statistics of DOH, look at the regions where they are highest because they're now about to declare a national emergency. Bakit kaya Region 3 at NCR nawawala sa listahan ng mga, they're also the same areas where the vaccination was either complete or partial. my own my own experience and my wife is she had one dengue vaccine case, but it was mild, and only one dose was given. So these are the things that I think should set the tone for this press conference. I asked the media to be partners. Yung vaccine, it's the range. But we must not forget that better information and better attention to care from both the families and the doctors are needed. And I'm very happy that the multi-sectoral groups here let all the weapons be available to our people. Bakit tayo lang sa buong mundo wala nang availability ng lahat ng weapons, including the vaccine? Thank you.
So reading from that line, better care, better clinical management, since dengue affected the majority are children, and we would like to hear the president of the PCP, Dr. Anna Ongli, to give us background, more information, how do we, or how can we help our children cope up or prevent dengue? Anna?
I'm sure lahat po tayo may kanya-kanyang personal experience about dengue. I'm sure meron po tayong kapamilya, kakilala na nagkaroon ng dengue. So hindi po kaiba tong sakit sa ating lahat. Alam nating dapat matakot tayo or at least maging concerned pagka merong kapamilyang nagkakaroon ng lagnat. Lalo na sa panahon to when we know that dengue is something that is spreading. So, kaya nakatuon ng pansin ng medical community sa bata pag dengue ang pinag-uusapan is because karaniwan sila yung madaling kalatan ng sakit. No? What do I mean when I say this? Yung clustering na tinatawag or pagkukumpul-kumpul ng mga nagkakasakit, karaniwang nangyayari in settings where kids congregate. So, nababalitaan natin parati kung may nagkasakit, hindi kaya kumalat dahil magkakasama sa school. No? So, isa po yun sa mga characteristics ng dengue dito sa ating bansa. Nagsisimula ang pasukan, tuwing halos tag-ulan. Pag tag-ulan, doon din ang pagkalat ng sakit. Pag kumalat ang sakit, saan pa siya kakalat, kundi sa mga nagkukumpul-kumpul na parati namang karaniwan ay bata. So, the reason why PCP and also the Philippine Pediatric Society, who I'm representing in this forum today, wants to be involved in this issue is because a lot of the patients who are presenting with this disease happen to be children, and we would like to emphasize na napakahalaga nung tinatawag na early health seeking behavior. Hindi naman natin sinasabi na lahat ng nilalagnat ay necessarily may dengue. Pero, maganda pong malaman kung dengue nga yung pinag-umulan ng lagnat na yun, kasi meron po tayong dapat na gawin para matulungan itong pasyente makaraos ng maayos galing dun sa sakit.
Okay. Before we open the floor, no, I just have to get some of the reactions of the panel, because I know later on you really have a lot of these questions. So that's for the pedia, one for the adult.
Siyempre, kung mga bata na apektuhan, pati na rin yung mga may edad. Recently lang, no, nung nag-admit ako isang pasyente na 74-year-old, no, ang history lang niya nilagnat ng 2 araw. No. Sabi ko, alam niyo po, saan po ba kayo nang galing? Sabi niya lang kwento, kasi galing kami sa States ng Buwana. Saan pa po? Nagpunta kami ng Cebu last week. Galing po kayo doon. So, ito lang pong sabihin sa inyo, kailangan po natin masigurado kung meron kayong dengue, Zika, o chikungunya. Kasi yung mga yan lahat meron dito sa Pilipinas. So, true enough, nung pina-check ko yung dalawa, kasi hindi na available ng Zika, nag-positive yung dengue NS1. And this is a 74-year-old female. And you will note na hindi lang talaga sa mga bata. So, kahit ng mga may edad, posible magkaroon ng dengue. At napaka-critical na mabigyan sila ng tamang advice kung anong dapat gawin. Kasi hindi naman dapat doon matatapos Hindi porke na na-diagnose natin sila, kailangan natin mabigyan ng tamang instructions on kailangan gawin. No? Hindi naman hindi ko naman sinabi kailangan ma-admit agad yung pasyente, pero sinabi ko kailangan marami siyang inom ng tubig, kailangan bantayan din ng ihi, at kailangan din bantayan ang mga komplikasyon o yung tinatawag natin warning signs. No? So yung warning signs, kasama din yan sa monitor. No? So pag nagkasakit, importante, mabigyan ng tamang advice para ma-monitor ng pasyente o ng mga magulang kung bata pa may sakit. Kailangan sabihan na kung may lumabas na warning sign, kailangan siyempre agad-agad ma-admit. No? Pero hindi rin nararapat na gano'n lang matatapos. Importante, mabigyan din natin ng instructions na dapat din pati yung mga heart rate, kung pwedeng bantayan, pati yung siyempre iba pang komplikasyon kagaya ng pagkukumbulsyon, o kaya pananakit ng tiyan, o pagsusuka. Siyempre, importante mabigyan sila ng instruction na nilagay ng bata o ang pasyente sa ospital para mabigyan ng tamang paraan ng paggagamot.
So, a little backgrounder lang po para sa ating media na we know that dengue is the fastest spreading mosquito viral infection globally. And according to epidemiology, nag-increase ito more than 30-fold eh. From Asia, it has reached Latin America, Africa, no, Pacific. And when yung epidemiology natin, the most recent from January 1 to January 29, 2019, it has increased to 85%. That's why ng July 15 na National Dengue Alert has been declared by the Department of Health. Now, yung most common, majority of those that are affected belong to 5 to 9 group. Yung group age is among 5 to 9-year-old. And then followed by 6 to 10, 10 to 14. So ito yung vulnerable age na kailangan nating bantayan because the data also shows na yung most common death, yung majority of this death also belong to this vulnerable age 5 to 9, followed by, yung 5 to 9 ang most common pa rin siya. Now, we need to capacitate. Yung importante po ang health education. Since ito yung mga bata, kailangan alam nila kung ano ba yung dengue, no? Maraming social media, PCP, no? Very active dyan, no? Importante talaga because in the beginning, ang dengue with no warning signs and severe dengue, they all manifest as one and the same. Walang pagkakaiba yan eh. It's only during the critical phase, no? That's when the fever starts to rise, no? Dadating ang mga warning signs, no? Na kailangan natin bantayan. Again, importante po ito for everybody to know. Ano ba yung 7 warning signs na ito? Number 1, ito yung tinatawag natin ang persistent vomiting. And then mucosal bleeding, and then abdominal pain, persistent, severe abdominal pain, na kahit anong ibigay mo na pain reliever, na hindi siya nawawala. Okay?